I'm the new chief psychologist for the Child and Adolescent Mental Health Division. My full name is Geniel Hernandez Armstrong, which is a mouthful. I typically just go by Dr. Jamie to make it easier for everybody. So just going to do a quick overview of CAMHD. I try not to use too many acronyms, but the Child and Adolescent Mental Health Division of CAMHD is CAMHD, and that's one we'll use quite a bit. And all the other ones, I try to make sure that I'm putting in there what they mean before I use all the acronyms that we have. Basically, we're just going to try to understand what our services are, how we function, and especially the crisis supports that are available, because I know that that's been a big question for people. So really, I just want to emphasize with this that all of our services are voluntary. We're just trying to help kids and families in the community. So who meets criteria? You must apply before the age of 20, but we service kids 3 to 21. I'll just say most of our kids are under the age of 18, because once they reach the age of 18, they have to consent to services themselves. They have to be physically in the state. That's not usually a problem, but sometimes they may be in DHS custody. So they might be in state custody in a different state. So we will also take those kids. The only things that don't qualify in terms of mental health diagnoses is if it's a youth that is only having substance use, so substance use disorder with no other diagnosis, and developmental disability as a primary diagnosis. For example, if they have autism that's level 2 or 3 and no other diagnosis, we wouldn't be able to service them. We just don't have the appropriate services for kids that have significant cognitive impairments. That would be developmental disabilities. They would have more appropriate services, but I do know that that is a group of kids that falls through the cracks. So if you have questions about that, we can talk about it later on as well. Really, all of these qualifying criteria and diagnoses is just to say that they need to be able to engage in talk therapy. Additionally, we're not seeing kids who have kind of lower level impairments. Maybe they're struggling with a little bit of depression, but they're able to go to school. They're doing all the things that they need to do. The kids that we're seeing, we're a carve out where we're seeing more significant impairments. So they have to have issues in multiple areas of functioning. And we measure that by the Child and Adolescent Functional Assessment Scale, or the I can't remember what PECFA stands for, but it's for like preschool. So we use these two measures to determine whether a kid is having enough impairment, along with diagnosis. We also look at adverse childhood experiences. So we're looking at a number of different measures, but these are some of the things that we're using to make sure that we're qualifying kids who really need this higher level of intensity of services. And again, like I said, our services are always voluntary. Often people associate us with DHS, child welfare. We have no affiliation with them, though we work with that agency quite a bit. But we just like people to know that you can end our services at any time. We're really just here to help. We're not going to force anybody into treatment. And we do have the new age of consent law where kids can get our services at the age of 14 without guardian consent. But those are only for in-home services, and we aren't able to provide medications for those youth. So if they want intensive in-home therapy or something similar, we're able to do that. And I'll get to more of what those services look like in a minute. So we have our family guidance centers. So they're on various islands, and we have several on Oahu, 2 on Big Island, Kauai, and Maui. And this link down here can give you where all the different guidance centers are and information about each of the different guidance centers. Within our guidance centers, we have our center chief, clinical leads, which is either a psychologist or a psychiatrist, mental health supervisor, and the mental health care coordinator. The care coordinator is the person that's really doing most of the direct work with the family. The clinical leads are involved as much as possible, but they're usually overseeing like 100 to 120 cases, where each care coordinator is getting like 20 cases. So the care coordinator is always a good point of contact. And then these are more like administrative people that work at our center. Our treatment team. So what is a treatment team? You might hear this term quite a bit when working with kids who are in CAMHD services. Treatment team includes anyone that's involved in helping the youth. So if as a physician, you want to be on this treatment team, or you want to come to a treatment team meeting for the youth, you're always welcome to do that, as long as they're agreeing to that, as long as the family and the youth are agreeing to have you on the treatment team. We like to include anyone that's a support to the youth. Treatment team always includes youth, caregivers / guardians, the care coordinator, and the clinical lead. But as I said, it can include other people. Often we have kids on probation and child welfare services. We try to include the schools as much as possible. So if there's any other people that want to be there to support the youth, we like to include them in the treatment team as much as possible. Okay, what does a treatment team do? Basically, we just make sure we're trying to get the best supports for the youth. And we meet about once a month to review progress and talk about any issues, work on discharge planning, and just generally supporting the youth and family. Okay, application for services. This is kind of brief, but I have the chat open, so if people have questions or you just want to unmute and ask me questions, that's fine. So we have an application on our website, which is probably in here somewhere, but I should have put it in there. There's two different kinds of applications: the family application and then the application through the schools. Only the family application is on our website. And we're working to make it so that people can just apply online. And then we can get that application without them having to fill it out and, send it in or whatnot. So we're working on that process, but unfortunately we haven't mastered that all quite yet. And was there a question?
I think it was just a blip. There we go.
Okay. So when someone's applying, say they come into the office for you guys and they're really struggling, you want to recommend that they do CAMHD services, you can help them by filling out as much of this as the family wants you to, as long as the guardian is signing that they will agree to be evaluated or agree to be contacted by CAMHD. We can contact them if there's contact information. Often we're having the schools fill this out for the family. Sometimes a different therapist is filling it out to help the family. So, and we don't need all of this information. If they don't have all the information, it's fine, as long as we're able to contact them. If we have contact information and a signature that I'm the guardian and I agree to be contacted by CAMHD, it's fine for us to contact them, and any information that's missing we can get later. We like to get it all up front, but sometimes we just have a name and a phone number, and that's fine. We'll get a hold of them. Does anyone have questions about this? Okay. And then we also can qualify youth under special education. So if a youth has a individualized education plan, they can come in under our services through Department of Education. So typically we're seeing, I would say, like 90% or more of the kids that we see are under MedQuest. Sometimes if they don't have that insurance, or the school wants to qualify them, they would qualify under IDEA, or the Individuals with Disabilities Education Act, which is basically that the youth has special education. So those are the two ways. And then we are also able to qualify kids that don't have MedQuest and don't have an IEP. It's like a temporary funding that we have. So we don't try to advertise it too much, because we don't always know how much funding there's going to be. But if a youth needs services, we're going to do everything we can to try to get them into services. So if you're worried about insurance, or you don't know if they have an IEP, just go ahead and fill out the referral, and we'll try to figure that out with them. So don't hesitate to put a referral in. We'd rather you try to get the kid in and we do what we can to get services for them than not get the referral at all. Okay. So after the application gets put in, we do an intake. So the mental health supervisor calls, explains a little bit about what our services are, and talk about kind of what we could offer. And then we schedule an initial mental health evaluation. Often that's done by the clinical leads at our guidance center, but it can be done by one of our provider agencies that we contract with. It can be done by a private provider. We often will get a brief evaluation from pediatrician or PCP or what have you, as long as it has the diagnosis, the current diagnosis, and a brief explanation of functioning. So, youth has been suspended from school, they're having suicidal ideation, or they're having impairment in their sleeping and eating because of depression symptoms or what have you. If you can give a general description of what the issues are and submit that with an application, that helps us to qualify them more quickly. We might need to do a little bit of follow-up depending on how brief it is, but we want to get kids in the door as fast as possible. So if we can do that by getting a little information from the physician, I think that kind of helps us to kind of speed things along a little bit faster. And then sometimes the school already has done an evaluation, so we can use those as well. But we're trying to use any and all evaluations to get them in, as long as it has enough information for us to say, this is the diagnosis and this is the current functioning, and it's showing enough impairment that they would qualify for our services. Does anyone have questions about that? Okay, so once they become eligible, the clinical lead determines whether they're eligible. They're assigned a care coordinator. We meet to discuss what best treatment options are, and then we have a welcome meeting where we talk to the family, introduce all the people that are going to be working with them, talking to them about their evaluation and what treatment options are available. And then when the family agrees to the services that we're recommending, we usually give them options. We can do family therapy or individual therapy, kind of depending on what the family wants. Once they agree to something, we'll start referrals for services. So we don't provide very many direct services. I will talk about some that we do, but we mostly contract out for our services. So I'll talk a little bit about services here. How do we decide what we're going to give them? We go based on the CAS principles, which are here. Basically, we want to be least restrictive, family focused, child centered. We talk about recommendations and treatment team meetings. So we don't just make those decisions as the clinical lead. We also want to get input from probation, from the schools, from other people that are supporting this youth to know what other factors are happening and what would be helpful. And then measuring over time how a kid is doing. So if they've been in a residential placement and the scores on their CAFIS and other scales are going down, and they have made progress on their treatment goals, we're going to start talking about different treatment options. Ultimately, it is the clinical lead that decides on the final service and authorizes services, but clinical leads are not making that decision without input from the team. This is our workflow. It looks very convoluted, but this is basically already what I talked about. And then we have this ongoing, clinical management, referring for services, making sure that kids are staying in the appropriate services, and then discharging. Our services typically are supposed to last about a year. So they're not long-term, and we try to get them into lower level outpatient services. But some of our kids just have higher needs, and they stay with us a little bit longer. For example, we often have kids who are in DHS custody, going in and out of custody, that we might have for a little bit longer because they have a lot of family transitions and things going on. Okay. I'm going to pause real quick, see if anyone, okay.
Actually, Jamie, can I ask a quick question?
Sure.
and maybe others are more familiar with these questionnaires than I am, but when you were talking about like the level of impairment that you need to have to qualify, could you give us some examples of like who would be a good candidate for being referred and who would not be impaired enough? You did talk about some of the exclusion criteria already.
Yeah, that's a really great question. So like I said, a lot of the kids that we're seeing, they have to have impairment in multiple areas. So if they're just fighting with siblings at home, or they're not minding their parents, that's probably not a good referral for us. However, if they're running away for overnight, nobody knows where they are for a day or more, or they are getting kicked out of school, they've been suspended on multiple occasions, they're getting into fights at school, or they're having self-harm behaviors where they're cutting themselves or other things to hurt themselves, that maybe it's not so severe that they need to be hospitalized, but they still are cutting, that would probably qualify for our services. Kids that probably wouldn't be appropriate are, I like to think of it as, would this kid benefit from somebody just talking to them once a week? In that case, that's not for us. If you're seeing a kid that really needs someone there several days a week, for our lowest level of care is 6 hours a week in the home. So that's the level of care we're talking about for kids that are going to get our services. So if they don't need that level and they could probably just see a therapist once a week, that's maybe not the best referral. But I would err on the side of referring to us if you aren't sure, because we'll take a look at that and we will try to qualify them if it makes sense for them to qualify. So that I would be thinking about, especially if you have a kid that's like on probation or has any of those other things going on, that would definitely be a kid that we would see. And for those younger kids that hopefully aren't on probation yet, and maybe they're not doing self-harm, but they're not able to be controlled in the family setting and in the school setting. They're acting out in public. It's a safety risk. They're running away from their caregiver, like running into the street, things like that. Those are the kinds of kids that we're seeing. So does that answer your question?
Yeah, that's super helpful. And I don't know if you're going to talk about transitions out of CAMHD, but Jamie has a question in the chat as well. I don't know if you can see it.
Oh, okay. Yeah, I see it. So her question: when a family child is graduating from CAMHD services, how are they treated while they're waiting for an opening? So we don't discharge them unless they have a transition plan. So typically we should be scheduling them for an outpatient therapy appointment, or a psychiatry appointment, and waiting until they have their first appointment and following them for about 30 days before we discharge. I hope that's always happening. It has been a problem in the past that kids have been discharged without things in place. So if that's happening, I would love to hear about it so that we can fix that issue. But I think we've made a big effort to make sure that our youth have transition plans. Sometimes the family or the youth says, we don't want you guys anymore. And then we can't really do anything about it. That does happen. Or if we can't contact a family or youth for 90 days, then we have to discharge. So there's a couple instances where that might not necessarily happen, but we try to make sure that they have outpatient therapy or psychiatry appointments, whatever is needed, before we're discharging them.
Thank you so much.
Yeah. Okay, so I'm gonna quickly go over our service rate. There's a lot, so if you have questions, just let me know. I've broken them down into in-home, out-of-home, and crisis services. So in-home services, every single kid gets intensive case management. That's basically, they get a care coordinator that helps them, helps the family with getting supports. And then our lowest level of care is that intensive in-home, which is therapy that goes to the home, or if the family doesn't want them in the home, somewhere like in the community, whatever's convenient for the family. And that's up to 6 hours a week during COVID. And if there were to be another, situation where we couldn't be meeting in person, they were doing telehealth appointments, meeting kids by Zoom and things like that. So even in the pandemic, we were meeting with kids, but it wasn't face to face. But now our providers are doing in-person therapy. This typically lasts 6 to 9 months, sometimes more, sometimes less, just depending on the case, and it's all ages. And we try to incorporate the family as much as possible. Some of our kids don't have families, so that's not always the case. We do evidence-based family therapies, our functional family therapy, and I put all the acronyms here for your reference because when you work with CAMHD, everybody loves using acronyms, so I'll try not to, but just so you know, if people are making these references, that's what it is. So we have 2 family therapies that are evidence-based. FFT, functional family therapy, is more based on helping traumatized families work on communication issues. And then multisystemic therapy was actually developed for use with kids who are on probation or having conduct issues, but it's actually really useful for caregivers that are having difficulty setting limits, or just having have some parenting skills deficits. So we usually use that to help with parenting skills. It doesn't necessarily have to be just for kids who have conduct issues. And then we have specialized services. The only therapy that we really have is for co-occurring developmental disabilities is adaptive behavioral intervention. And again, they have to be pretty high functioning. So we have some high functioning youth with autism, or like lower level cognitive impairments where it's not so impairing that they can't talk, but they can understand what's going on in therapy. So we can do adaptive behavioral intervention, but it's not, we can't really work with kids who are nonverbal or who are too cognitively impaired to understand, thoughts, feelings, behaviors, types of things. We have independent living skills for kids who are transitioning to adulthood, on track for first episode psychosis. This is only for ages 15 to 21, but it's a longer term service, and we're trying to expand it to be younger and older, and working with kids who maybe aren't in the CAMHD system. But it's a very new program, and so we need to work on our capacity and hiring some new staff. But we've had some success with helping kids who are suspected of having first episode psychosis and getting them evaluated, and then kids that we have determined that they're having psychotic symptoms. Intensive outpatient, this was with Kahimohala. Right now they've closed the program because they are having staffing issues, but we're hoping that they'll reopen that pretty soon. And this is like higher level support for kids who are only on Oahu because they go home at night, but it's just to stabilize them while they transition back to the home setting. Okay, out of home services. Did anyone have questions? I'm checking the chat. Okay. So we have our transitional family homes, or some people have referred to this as therapeutic foster homes. We changed the name to transitional family homes because we were having issues with kids in child welfare services, DHS custody, being kept in those homes for too long without a transition plan to like a guardian or something. So we renamed it, but it's the same thing. And it's 6 to 9 months with a therapeutically trained family. They do individual and family therapy, working on transitioning home. They do visits back home, and they're doing family therapy with whoever the caregiver is to help them get back home. And we try to use the out-of-home services in a very limited capacity because we know that it's traumatic for kids to be out of their home setting. It's really difficult to be transitioning from one thing to the next. and having to maybe go to a new school district and make new friends. So we really try not to use out-of-home services if we can help it. But like I said, we have really impaired kids, so we want to make sure that we have services if they're at needing a higher level. We have several community-based residential treatments. Right now, we have Pearl Haven, which is a treatment for sex trafficking victims and youth at risk for sex trafficking. Bobby Benson Center, which used to be for substance use only, but they've now opened a non-substance use treatment program for all genders. We have our Catholic Charities program for sexually reactive boys, and then we have our benchmark locked facility for sexually reactive boys. So that would be our highest level of care, is a locked facility in terms of residential treatment. And then we have hospital-based residential, which is actually our highest level of residential, but it's shorter term, 4 to 6 weeks at Kahimohala. Did you have a question? I saw someone unmute there. All right. So, and then we do have out-of-state services, but again, we really try not to do this because it's our most restrictive level of care. And we really only use it when we've already tried everything in state, or the youth needs such specialized care that we don't have it in the state, and they're not going to be able to benefit from the services that we have. The reason we don't really like doing this is because it's really hard to transition youth back. It's hard to do visits. It's hard to do family therapy. Youth are more isolated, and they don't have, they're not in their normal setting in any way. And it's just really hard to transition to a new type of therapy because they're so remote. It's actually cheaper to do, sadly, but it's not best for the youth that we work with. But in some extreme cases, it just has to be done. Any questions about any of those things? More services. So we have our family court liaison branch, which is at the detention home and our correctional facility and our shelter. They do a lot of therapy for the kids over there if they will agree to it. And a lot of it has to do with safety planning and suicide intervention, and then discharge planning and support. And they also have medication management. These are all supplemental services that can be added on to an existing service. Just a parapro or paraprofessional who kind of helps supplement these different types of therapies. We can give one-to-one support if a kid needs it. We have therapeutic respite homes, and that's a planned respite for 1 or 2 days in a transitional family home with a trained family. But it's planned like, okay, the second weekend of the month, you're gonna go with auntie, whoever, and it gives a break to the kid and the family, but we don't use it as like a crisis. This kid needs out of the home today, because we don't want kids feeling that they're being pushed out of the home because of their behaviors. And then we have transitional support services to get them back from a residential program, and then our KLHO services for trauma-focused intervention. This is mainly for youth who identify as female and have a history of trauma, but they're able to do trauma-focused cognitive behavioral therapy, which is an evidence-based intervention for trauma. Clinical leads also provide some supports. Our clinical lead psychiatrists provide medication management to youth that have other CAMHD services. Some of our clinical leads, not all of them have the capacity because different centers have different staffing and different numbers. So some of the clinical leads provide individual and family therapy. Some centers have student therapists that are able to do different types of therapy. Right now at East Hawaii, we're working on a PC care intervention, which is for traumatized youth, and it's like 7 weeks, and it's kind of short term, and it's 1 hour a week with the family. So these are kind of lower level interventions. And then we have telehealth groups that are available to anyone in the community. So if you have youth that you think would benefit from dialectical behavioral therapy, where maybe they're having chronic suicidal ideation. They're extremely emotionally reactive and will engage in things that are possibly self-harming. That would be a good group for them, and they're able to do that with a caregiver. We have caregiving skills group and a girls circle. We're starting the boys council, I believe, over the summer. So these groups are, kind of ongoing. They run at different times, but they're all the flyers are on our website. Okay. We also have parent support services, which is also known as a parent partner, youth partner. And then we have this Help Your Keiki website that actually has a lot of really good resources for families. If you're just trying to get families information or they have questions, this is a good resource. And there's direct link to our application. And there's also a way for them to search for providers through their insurance. So it's a great website. I'd really encourage you to give it to families that might be struggling, but maybe they're not ready to fill out the referral, or they're nervous about filling out the referral. They can look at this website and maybe get more information, and then maybe they'll decide to do the referral on their own. So I'd encourage you to take a look at that website if you have a chance. Crisis support services. So we would define a mental health crisis as potential harm to self or others and actively psychotic. I just want to put in here that I've added risk of being sex trafficked and running away with known dangerous people, because that's something that really has been an issue. I did some trainings with emergency departments, and I think they weren't aware that there was a sex trafficking issue in our state. There is a sex trafficking issue on all islands, and a lot of the kids end up going to Oahu. So if you have a youth that's coming in and you're seeing like maybe they're using substances, maybe they're coming in for STD screening, things like that, and you're not really sure, but you think there might be something going on, that there actually is a call line that you can call. You can call Hawaii Cares and they can give you resources. But I just want people to be aware that sex trafficking is an issue in our state. And we've had a lot of youth that have either been run away and haven't been recovered. So we have a really high risk population, even with youth who have families and parents that care about them. Sorry, there's a question. Do telehealth groups need a formal CAMHD referral? No, they don't. So for the telehealth groups, that's for anyone in the community. Anyone can come to those. As long as they're, within the appropriate age range. So just that, and but any youth can do that. Okay. Hawaii Cares line. This is just some general information. I'm working really closely with them because I run the crisis response task force, mental health crisis response task force. They're making some changes. It'll be the same call center for 988. So if people call 988 or they call the Cares line, both numbers will be available, and everybody is going to be going to the same call center. So this is kind of confusing because the call line, Hawaii Cares, is run by AMD because they serve all ages. We run the crisis mobile outreach team that goes out to calls as needed. So I kind of think of it as, if you're calling 911, you're not going to get the 911 operator coming out on a call. They're going to send the police or whoever. So we would be the people sending out people for the call, but we're not answering the phones, if that makes sense. What is crisis mobile outreach? It's 24-hour response from the call center. They're supervised by a licensed mental health professional. There's a psychiatrist or med provider available 24/7 that consults before they go to the emergency department. And this is just kind of what experience they need to have, because I sometimes get that question, so I put it in there for you. So what happens here, it's kind of the step-by-step. They get a call from the call line and they dispatch to CMO. There's different providers on the different islands. So CMO providers or crisis mobile outreach providers are different for each island. The worker will call within 15 minutes of getting the call, determine what the crisis is, talk to whoever's calling, see what needs to be provided in terms of support. And then they're supposed to be responding within 45 minutes of receiving the call. I know that doesn't always happen. So we're working with them to do that. Part of the issue is that we only have a limited number of call center workers. And if you're on, if you're on Big Island, up in Kohala and you get a call in Ka'u, you're not going to be able to make it in 45 minutes because it's 2 hours away. And we have a limited number of workers. So we're trying to work on that. What they can do, they do recommendations for emergency room. And we also have some other services that I'm going to go through, therapeutic crisis homes, residential crisis stabilization, and some other supports. They can't transport youth, and they can't respond to calls where a youth is so aggressive that really the police need to be intervening. Let's see. So we have some of the resources here that they can access through crisis mobile outreach are therapeutic crisis beds. And this is just a home that's a transitional family home, a trained family where they can stay for 3 to 7 days, but they can't be like acutely suicidal because these families can't watch them 24/7. But if they're too high risk to go home, or the home is where they're being triggered, they can stay in this setting while we get some other things in place. And they aren't attending school. So it kind of tells you like the level of intervention that's needed if a kid is not acute, but they're not quite ready to be back in the home setting. And this is just who the providers are. We have our Hikimai Kala program on Oahu, which is a residential crisis stabilization program for 30 days. It's on Oahu, but we have kids from all islands going there. And it's really just to stabilize them while they transition to different levels of care. So sometimes we have kids coming out of Kahi or Queens, they go to residential crisis stabilization before they go home or before they go to another residential program, just as a way to kind of make sure they're stable before they go. It's an 8-bed facility, and they do really great therapy. This is one of our better programs. They have really good individual and family therapy that's provided throughout the stay, and medication management as needed. Really? That was it? Okay. I feel like I breezed through that pretty quickly. What questions do you all have for me, or things that you'd like me to go over more in detail?
I'll run the post test really quickly, and then so we can review the answer to those as well as questions from the audience. I'm just going to launch the poll and give everyone 60 seconds or so to put their final post test answers in.
And when we do finish the poll, first of all, thank you so much, Dr. Jamie. That was like incredibly wide-ranging and useful. And I can't tell you how many times I've heard, oh, so-and-so is in CAMHD getting this or that. And I really didn't have a clear understanding at all of what's available or how like just it like physically works. So I didn't know Pearl Haven or any of those other, treatment facilities were connected to CAMHD. So all of that is super helpful. I imagine there are probably a few more questions, but there is one in the link in the chats that is from Assad, who is a triple boarded child psychiatrist. I mean, triple boarded, but also including a child psychiatrist. So maybe once we finish the questions, you could respond to that, because I think he's probably not the only person who has that question.
Yeah, let me put the link to our website in there. I'm sorry that I didn't put it in my presentation. It should be in there, but it's that's where all the information for the website or for the groups is, and the contact information. I can also give you the contact information for the person who runs the groups. And like I said, not all the groups are running right now. Here's the link to the website. And you'll see under our services, the information about our different programs and resources for families. That's where the DBT skills group and things are there. The information is there. So sorry, I'm I'm looking at multiple screens on one screen at the same time to try to get all this information. But I believe, let me get her, I'm trying to get her contact information up here so that I can, actually, what I'm gonna do is I'll just share my screen. Are you guys able to see this?
Yes.
Yeah.
Okay, so this is the contact person for all the groups actually. So it's best to just email her. She's not an intern anymore, but they won't change her email. I'm not sure why. It's just one of those like government things. But if you want to contact Dr. Alex, she's really great. She kind of heads up doing all the groups. And our groups are run out of East Hawaii Family Guidance Center. I think the plan is to eventually have them be back in person. So it, you know, if you have kids on Big Island, I think you guys are all on Oahu though, right? No, not.
I'm not sure who's here today, but we generally have an assortment of people from different islands, and then often a couple of people from Guam. I think our colleague from Guam is here. I see someone from CNMI.
Okay. So I'm just showing you, this is our website. So under services, resources for families, this is where you'll see Girls Circle, DBT group for teens, and then a number of other resources. We have a safe spaces committee, help your keiki. And so there's a lot of resources under here. So sorry, they're getting, it's, I feel like there's always something binging at me. My email, my two phones. So just wanted to let you all know. And then here's our application. So I just, it tells you all the different centers and where to send the information and phone numbers for all the different centers. And I'll just show you where they need to sign. So this is where they need to sign. And then all of this other information, that's great, but we really just need a name and contact information. So if you aren't able to do all of this, or the family, it can sometimes feel overwhelming for families to do all this paperwork. So go ahead and just reassure them, put whatever you can, whatever you want to, they'll call you and talk to you about it more. You don't need to fill out every single space. We're not going to reject the referral because it's missing, you know, the zip code or something. We really are very focused on getting as many kids in and getting services as we can, not so much making sure the paperwork is right. So it's pretty lengthy. And if you do help them, just make sure that you you want to be involved in the case, just making sure that your information is on here, so that we can contact you as the referral source if the family is okay with that. And then the rest of this is just checking boxes about, you know, who they can, who they're releasing information to.